Those of you watching in 3D can kind of see how much higher the brow and the malar eminence are than the corneal surface. Well, clear corneal temporal surgery made that a lot easier. When I irrigate the cornea, chamber is nice and deep, and we're going to use the side port blade oriented in this right eye with the blade superiorly. Just enlarge it just the slightest amount coming out, and that's so the big ball chopper fits nicely. And there's our temporal clear corneal 2.4 millimeter incision. So with deep set eyes, you'll obviously have to be approaching the eye at a more acute angle whenever any instruments come from top or bottom. But when they come from the side, well, not an issue. So what does that mean? The chopper. That comes sort of superotemporal mostly in right eyes, inferotemporal in left eyes. So I've done the viscote, provisc, and now I'm going to do the capsulorhexis. So instruments, like I'm coming pretty steep here with the spatula because that's what the anatomy causes me to have to do. Alright, so let's do our capsulorhexis. And you can see some stria in the capsule there as I do that. So the zonule might be on the lax side in that region, which was inferior and inferonasal. So we never want to stress a zonule, but let's pay particular attention to avoiding zonular stress here. So there's hydrodissection done on one side and then the other. And now viscodissection. And because there may be some zonular laxity, I'm doing the viscodissection for a full 360 degrees here. See the nucleus kind of rotated as I was doing it. Okay. So let's test infusion capacity. It's quite good. Place our chopper right at the side port and introduce the phaco tip and then pop in with the chopper. So I've removed cortex and alright, so stabilizing the nucleus. The more it's stable, the less the zonule feels stress. So I've got the chopper out over the equator to start the procedure. And you can see this nucleus is pretty dense, scale of 1 to 10, 7, 7.5. But notice how stable it is as I sculpt it. And the reason it's so stable is because the chopper held it that way. Okay, so let's rotate it without stressing the zonule. Wet the cornea, please. And how might one do that? So by pulling here with the left hand and pushing with the right, the lens spins in situ. So let's now do a chop right here, and we're ready to remove a quadrant or a segment. Quadrant removal. So first aspirate cortex so I can see it, and if I can, I'm going to slip the chopper behind it and then just pull it centrally. So now I'm going to get this quadrant removed. Wet the cornea. Actually, I think possibly 2 quadrants. And now what have I accomplished? So I've decompressed the capsular sac, You see I had a couple of free floating pieces here. And when you decompress the capsular sac, all my subsequent chops, sculpt please, are going to be in a decompressed sac, wet the cornea. And the best way to hold the nucleus still when you chop it is to impale it like this. Boy, the zonule doesn't feel anything when you do that. So you can run it back in slow motion and see what I did. Foot pedal 3 to 2 real quick. And then stay on 2 while I chop. Quadrant removal. A very important maneuver to practice. You can practice that maneuver, you know. You don't even have to be in an eye. So know the treadle on your foot pedal and the feeling of going from 3 to 2. So there's my last nuclear segment. Spatula protecting the posterior capsule. And now we're ready for INA. So if the zonule were lax, we never knew it because we never did anything to test it. So the next step, test infusion capacity. You can see the patient moving, squeezing. What does that mean? The anesthetic's wearing off. So we got one or two choices. Give them more sedation or let them wake up. So let's see. Are you awake? Okay. Do you need to be more sleepy or are you okay? You're okay. So it's important not to move now, all right?
Okay.
Huh? Yeah, don't move. Okay, everything's fine. You're going to feel water on your eye. So now I'm going to test to see, does she stay still with the water? Pretty good. Still a little twitching, but not so bad. Okay. Nice and still. So I'll maintain contact with her now as we finish. Okay, still a little movement there. So we're going to tape her head. And it's now been about a minute since we've given her a little more sedation. Twitching of lids is minimal. So let's put a little fluid on, see how much twitching we get. Just a little bit. I'd like to see that disappear, and it probably will. Yeah, there it goes. So at around a minute and a half maybe. So we're very important. If in the middle of a procedure, beginning, it doesn't matter when, cooperation becomes less than optimal, do something about it. And that could be in the anesthetic category, usually is. And you can see the spatula holding that. Those of you watching in 3D have got a great view of that. See that capsule? So it came forward. If I weren't protecting it with the spatula, we might have had an adventure, right? Okay, so that's infusion misdirection. And with the lax zonule, you'll just see it all the time. Okay, so now it's time to put in OVD. And here's another great thing for you, wet the cornea please, watching in 3D to see. You can see where the posterior capsule is by that PSC opacity, and you can see where the little microscopic lens fragments are on the anterior hyaloid. Look at the size of the space in between. Now, watch what happens when I inject OVD. First, I'll inject it and I'll take the PSC off. And watch how the posterior capsule goes right back to the level of those fragments. How does that happen? What just happened? The fluid that was in that space left. Where did it go? Sideways. Did it go back into the vitreous cavity? No way. Came through the zonule back in the anterior chamber. Okay, so now look how deep. Again, the 3D view is so great for this. How deep the posterior capsule is. The fragments are right at the level of the posterior capsule. And we've got a normal anatomic situation. Easy IOL insertion coming up because we've got a big space to put it in. What if the posterior capsule didn't go back? Those are the cases where you get concerned that maybe there's a choroidal. Now that's rare. It's almost always infusion misdirection. But could it be a choroidal? Capsulorhexis forceps. And what happens if you couldn't get a nice space? Don't force the issue. I was going to use the capsulorhexis forceps to release the haptic, but it did it by itself. Stop, get an indirect, take a look around, make sure there's no choroidal because you don't want to proceed. And if there is one, you just stop. And then put the IOL in a week and a half, whatever. But opening the eye and getting hypotony is an invitation for that choroidal to expand and have trouble. So that's your differential diagnosis. You can overcome it with OVD. It's not a choroidal. And if you can't, it still might not be a choroidal, but it could be. And you got to rule it out. Seeing the fluidic space between the posterior capsule and the anterior hyaloid certainly is diagnostic. It tells you what it is. Okay, so now take a look. There's the posterior capsule, and there's fluid back there again in the space between the posterior capsule and the anterior hyaloid. So during INA, as I removed OVD after IOL insertion, it went back there. And there's a little PCO there. Probably not enough to be visually significant. So this falls now into a little bit of advanced technique stuff. You can go in with the syringe, lift the IOL, and go down and just kind of rub that capsule as you irrigate on it and get that PSC that didn't come off originally. Get it thinner so you don't have to do an early YAG here. And then I just recentered the IOL. And there's still a space between the anterior hyaloid and the posterior capsule, but that doesn't matter now because we're done. And that anterior hyaloid will come forward and get right up against the posterior capsule post-op. And if it didn't, it wouldn't matter, but it will. And we're done.